Tonight, the speaker is Joseph Dumit. He's going to be talking about maximum prescriptions, growing health and happiness through facts and pharmaceuticals. And Joseph Dumit is Director of Science and Technology Studies and Professor of Anthropology at the University of California, Davis. He is the author of Drugs for Life, the book that I see around in the room, How Pharmaceutical Companies Define Our Health, and Picturing Personhood, Brain Scans and Biomedical Identity, published by Princeton in 2004. He has also co-edited Cyborgs and Citadels, Anthropological Interventions in Emerging Sciences and Technologies, Cyborg Babies, From Techno-Sex to Techno-Thoughts, and Biomedicine as Culture. He was Associate Editor of Culture, Medicine, and Psychiatry for 10 years. He's a founding member of the Humanities Innovation Lab, and is currently studying how immersive 3D visualization platforms are transforming science. And particularly, he uses a cave to do this kind of work. And I gave me an illustration earlier today, which I will post separately on my blog. He has begun work on a new project on the history of flowcharts, cognitive science, and paranoid computers. So if there's any one person that I met at the Center for Global Humanities who embodies future trends and the meaning of the future and the present, it's got to be him. And he's leaving today to go, actually driving after all is done, to Brown to give a talk at Brown University tomorrow, then continue on in New York to give a talk at the New School for Social Research, and then at NYU. So he has a lot to say about this gray area where science and the future meet the humanities and other things. So please help me welcome Joe Dumit.
All right, thank you, Anouar, for that wonderful introduction, and thank you to the Center for Global Humanities and University of New England. It's a real pleasure to be here. Yeah, the gray area. Let's say that this talk is about the gray area. I think some of you have looked at my book. I'm going to kind of go through parts of that and go through some of how I've come to do this work. I'm an anthropologist. I study how science and medicine change. So my goal is to kind of look at how change happens. And in this case, I got drawn into trying to understand, how prescription rates could keep going up. This was the mystery. I first started getting really fascinated with just pharmaceutical advertising. But when I talked to marketers, it turned out that they said that the advertising wasn't what really drove pharmaceutical consumption. It was clinical trials. So I'm trying to kind of understand this, and I've talked to lots of economists, like how can things just keep going up? So here's the projections. The most recent data is up to 2022, but I didn't have a nice graph. So I didn't have a nice graph for that. So here you can just see the kind of total growth in billions of dollars for national health expenditures. And on the bottom, up to 19.3 there, but by 2022, it'll be 19.9, 20% of our entire gross domestic product. So more and more of our entire economy is going toward health. So it's kind of weird when you think of it, right? We're getting more and more scientifically, medically advanced. We're getting better at distributing things to people. You would think that the more we know, the less we would have to spend on health. We could just kind of target things, and we'd spend less. We'd put less into our bodies for health. And instead, it's the opposite. So I tried to kind of dive into this. And you can just see like the number of prescriptions for these drugs keep going up. This is clinical trials. This is the percent of clinical trials going overseas. A lot of my other anthropological friends have been studying things like the clinical trial outsourcing industry, the clinical trial insourcing industry in the US to contract research organizations. And so this is what I want to try to present to you today is I spend a lot of time as an anthropologist. Our method is called deep hanging out. So I hung out with marketers. I hung out at direct-to-consumer conferences. I hung out with a lot of literature. And what I want to give you today is, in a sense, how the pharmaceutical industry sees us. And then most of what I'm going to present are quotes from the industry about themselves. And so This is stuff that's not secret, but it's just a different way of looking at what they're already saying. And so the poster that really struck me a couple of years ago in a bus station, "Get well soon, we prefer stay healthier longer." And by the end of this talk, maybe it'll seem a little creepy. So my method, ethnographic engagement, a lot of what I've done over the last 12 years is I've done grand rounds in medical schools, at psychiatry departments, I presented to mental health services, I presented to marketers. A lot of my research, my insights, the way I'm going to talk today, come from presenting to these groups and hearing the way they hear what I say, and kind of figuring out how to talk about this in a way that gets at the kind of core dynamics within the industry. Logics, grammars, regimens, these are different ways of thinking about, like, how have we come to talk about health differently? How 40 years ago did we talk about health such that now, if we went back in time 40 years, people would not understand the way we talk? You know, a small example of that I'll go over a little bit more in detail is, you know, today, all of us talk about, I have a risk for something. We use the exact same grammar as I have a disease for something. So that risk, the risk of a future event, which, you know, for most people, for something like a heart attack is, you know, 5% over the rest of their life, maybe a lot smaller for many of you in the room, and yet you have a risk for it, and therefore you can take something for that risk. So this idea of thinking of risk itself as a disease and therefore in need of treatment is a new way of talking. Now there are good, you know, medical scientific reasons for doing that, but that is a change that underlies, in a sense, why there's been this kind of growth. So part of it involves, you know, thinking with the anthropological literature. Marilyn Strathern's an anthropologist who writes that culture includes the way analogies are drawn between things, the way certain thoughts are used to think others. Culture consists in the images which make imagination possible, in the media with which we mediate experience. This is a fancy way of saying that the way in which we come to think about the world, the way in which we come to think about possibilities for the future is shaped by the images around us, by the language that we're given. In a sense, by our training. So here's one cartoon that circulates. Your blood pressure is off the chart, you're overweight, out of shape, and your cholesterol is god-awful. In short, I find you perfectly normal. I've seen the same cartoon with a different caption. The good news is that your cholesterol level hasn't gone up. The bad news is that the guidelines have changed. So as an anthropologist, I'm really intrigued. We all, in a sense, find these funny. And they're both, in a sense, true. Right? What we find funny is usually something that involves a slight anxiety about these things, and yet at the same time it's true, and so we oscillate a little bit. And I'm interested, in a sense, is how have these both come to be true? Part of it involves this kind of poster. Are you the picture of health? You might look and feel fine, but you need to get the inside story. Colorectal cancer often has no symptoms, so please get tested. I did. So here's a relatively new way of thinking about us. That the very fact that you feel fine and that you feel like, oh, I'm healthy, is itself a symptom, right? If you feel fine, you're probably not looking deep enough. You should get checked. It's a certain type of anxiety that underlies a way in which we live today, that you can't just be yourself and feel good. There's things that you can't know about yourself that you need to get tested.
Getting high cholesterol down is important. For some people, it's even more important. You've been to the doctor, good. You've changed your diet and are getting exercise. Excellent. You've tried just about everything. Now medical information comes along that says you may need to get that bad cholesterol even lower.
Notice that this staircase has no end.
Well, if your doctor says aim lower, ask about Crestor. Crestor, along with diet, can lower bad cholesterol by up to 52%. That's about half. Is Crestor right for you? Discuss it with your doctor. Crestor is not for everyone, including people with liver disease. And women who are nursing, pregnant, or may become pregnant. Simple blood tests are needed to check for liver problems. Tell your doctor about other medications you're taking, or if you experience muscle pain or weakness, as that may be a sign of serious side effects. Do you still need to get your cholesterol lowered? Aim lower with Crestor.
So I'm only going to show one other, but I've collected over 200 pharmaceutical commercials, and I'm really interested in the entire grammar of this. And if you go to Europe and play these, which I have, people kind of freak out because they're not used to this kind of very overt way, and just the very sense that you can address everyone with a commercial whose job it is to, like, literally the marketers are told that their job is to get you in, get as many people in as possible to get checked. And it's an interesting balance that they're in the middle of. So what I want to do is, here's one way of thinking about a shift, a kind of individual health model in which symptoms interrupt a patient's life and drives them to a doctor. The doctor then takes their history, examines the patient to make a diagnosis. Doctor then prescribes treatment, and the treatment returns the patient to health and is discontinued. So that's one model of health. And there's one that I want to call more attention to today, because this is the largest growth in treatment, which you could think of as a mass health model. Little or no experience of symptom until attention is called to them. This is the reason why you need to watch a commercial to learn that you need to do something, because there's nothing in your body driving you to this. The patient or doctor takes a checklist or screening test to discover that they have a treatable risk. So I'm using that language here, a treatable risk. The clinical trial is what indicates treatments, so that many doctors have talked about the fact that they are losing more and more autonomy because they can't even see if the patient is sick, and the treatment often has no discernible effect and is indefinite. So that doctors, and this goes back to the 1950s and the beginning of statistical medicine, which itself was a big fight, which was a doctor who now can't actually look at the patient and see if they need something, and even after they give the treatment to the patient, can't tell if the patient is better, because the treatment itself only helps 3% of the people. But because of the way the clinical trials have been structured, we don't know which people. So the doctor prescribes a treatment, and then the doctor can't tell if it's working, has to rely on the clinical trial itself to know that this drug helps. So it's just a story that a lot of doctors talk about, which is a shift in the way their training works now. And this leads to a kind of difference if we think about inherently healthy versus inherently ill. So the kind of individual model, the first one I showed, is one in which you're kind of presumed healthy until something happens to you, versus one in which you're, in a sense, inherently healthy. Like, we all have risks, right? We all have some risk. So the question then becomes, where do you draw the line? What is the difference between a risk and a treatable risk? So here, something I've been working with for a while. This is the original Prozac website. Actually, Prozac.com is gone now. It doesn't exist. It's as a generic now. I guess Lilly just didn't want to maintain even the brand. And I'm interested in this little chart here. So here is a depression curve. And the first thing you might notice in the upper left-hand corner, there's normalcy. And then normalcy consists of having symptoms, but if you have enough symptoms, they add up to a syndrome, right? And that's a relatively new way of thinking about diseases, as syndromes as, if you have 5 of 13 symptoms, then you kind of cross a line into symptom. And one of the ways of showing this is, like, on the website, you click on this, and you went to a little tool to discuss your symptoms of depression. And the first thing, we can look at these things. I don't want to go into them here, but they're, both interesting and sometimes amusing. I feel downhearted, blue, and sad. Morning is when I feel the best. I click not often because I'm a night person, and I never feel good in the morning. I have crying spells or feel like it. I have trouble sleeping through the night. I eat as much as I used to, which is a kind of really brilliant grammar. I enjoy looking at, talking to, and being with attractive men and women. I notice that I am losing weight. Now, all of these have specific histories in depression studies. Like, there are reasons why they're there. The putting together in this particular website, though, no matter what you fill out on a website like this, when you click a button, it says, you should see your doctor. Because for legal reasons, you can't get diagnosed. Therefore, they have to send you to the doctor. In a sense, the very fact that you're taking this test means that you should see a doctor. Another thing to notice, and David Healy's done some really interesting work on this, is there are lots and lots, someone said 600 different scales for schizophrenia. I'm not sure how many for depression. The literature is full of different fights over kind of how we define depression. what David Healy tracked was that if you have a drug and you're going to design a clinical trial, what intake criteria that people have depression are you going to use? And then you give them the treatment, and then what you're going to do is then give them that same quiz at the end, and hopefully they'll improve by a few measures. Now, if you have on that quiz, out of, say, 20 questions, 3 questions that have to do with sleep, and your drug happens to help someone sleep better, they're going to improve on your depression score better than, say, a competitor's drug, because that score is more tailored to the drug. And there's nothing inherently right or wrong about this, because there's a constant fight over what really constitutes depression. But companies are, in a sense, producing a package, and it's what it's called, that includes a particular scale and their drug. And so this is the kind of first level of this. The second one is that this is part of a type of marketing campaign in which the first level is awareness. That you have to know that something like depression exists so that you can then personalize it. And the personalization, and these are all terms from the industry, from marketing. Personalization is when you come to think that you might have something like this, that this is something that might apply to you. Self-diagnosis is the act of taking a quiz or something like this, or even just the commercial listing some symptoms that you recognize as potentially about yourself, that then means that you should take action, meaning going to the doctor. So the whole first phase of marketing is about this kind of marrying together of awareness to action to get you in.
Your doctor probably never sees you when you feel like this. This is usually who your doctor sees. That deeply depressed you who barely dragged yourself in for treatment. That's why so many people with bipolar disorder are being treated for depression and not getting any better, because depression is only half the story. That fast-talking, energetic, quick-tempered, overdoing it up all night you probably never shows up in the doctor's office, right? Log on to bipolarawareness.com, sponsored by Lilly, on WebMD, the place for healthcare answers. Take the test you can take to your doctor. It can change your life. Let your doctor in on it. In order to make a correct diagnosis, your doctor has to know about your ups as well as your downs. Getting a correct diagnosis is the first step in treating bipolar disorder. Help your doctor help you.
So here we have an interesting example of a commercial right at the beginning of the Zyprexa campaign, where, I mean, in that commercial, if you notice, this woman, in a sense, has to watch TV to find out that she's been misdiagnosed and misprescribed, and then takes this test, hands it to a doctor who very smilingly is like, oh, thank you for telling me how bad I've been at my job, and then gets her the right diagnosis. So I'm kind of interested in a lot of things in this. One of them is that in all of the mass consumer commercials, it's always your doctor. It's never a specialist. And there's a big push within the industry to actually, target primary care professionals, physician assistants, nurse practitioners as prescribers, because they have less time, less training, and in many ways are their target market because they're doing the mass prescription. And so the industry talks about this. They call them invisible prescribers. And this was an article from 2006 in Pharmaceutical Executive. This was one of the archives I used. It's a magazine within the industry about marketing. And this is just talking about physician assistants and nurse practitioners as the hidden one that you, as a company, might not be aware of that you could target more. So this article is all about how you can maximize your prescriptions more through these markets. And you can see up above that time spent with patients, 11 to 18 minutes. So here what they're saying is actually compared to primary care physicians, nurse practitioners and physician assistants can spend more time so they can do more prescribing. And they also point out that primary care physicians, on the other hand, report spending an average of 2 to 5 minutes per patient. So this is just one little window into this. I'm going to move fast through this whole thing, and we can talk about whatever you're interested in afterwards. So now I want to pay attention to the upper left-hand corner here, normalcy, in quotes, right? It's a kind of weird thing to put normalcy in quotes, as if you're never quite normal, of course, because by definition, you always have some symptoms. Like I have always one symptom of depression just by being a night person, according to that particular study. But it's underneath that is a different way of thinking about the fact that we're all we might be going well, but there's always something to fall off of, right? It's a different image of a disease. There used to be this robust image of disease. Health is down here, and illness is when you kind of go off of health. But normally you get ill and then you fall back down, right? Your body's robust, it returns to health. Maybe it gets pushed so far up that you need a drug or something to help you and it kicks you back down, right? This is one image of medicine. The newer one, the additional one that we've added to this, is one like this, where it's very precarious. Health is kind of you're balanced precariously with all of these risks, and when one of those risks happens, you fall, and then you need a drug, and the drug props you up, and you never quite get to center again. And then here I'm just talking a general grammar of how we talk about this. So the issue, though, when you add up symptoms to a syndrome is one of pre-diseases. And all of these different pre-diabetes, pre-hypertensive, borderline high cholesterol, the kind of like, well, what if you don't have high cholesterol, but you're really close? I mean, maybe you should take a statin anyways. Or maybe you don't quite have all the symptoms that add up to depression, but maybe your physician thinks, well, we should try. We should try this drug to see if it works. And when I've talked to physicians, they talk about that this grammar has started inhabiting them. You know, a different way of thinking about prescription. Here's one from the National High Blood Pressure Education Committee. The committee felt that the term pre-hypertensive would be more of a motivating tool to get people, physicians, clinicians, and patients to do things. And this is one of the paradoxes of public health, right? This is something public health always struggles with. It's a good struggle. It's a question, though, like what does awareness mean? Like if you're aware of something, can you be aware of it and not get checked? Because from their perspective, you know, to be aware of something means you're getting checked. So there's actually no difference between awareness and doing something about it. And so, you know, I'm interested, again, as an anthropologist, the attention to choosing what to call something like pre-hypertensive because it sounds like you have something. So they're very explicit that they're choosing to kind of name the propensity for something to be a thing. Like I am pre-hypertensive, I have pre-hypertension, I'm getting treatment for it. Here's a way of thinking about the distance. So this is a 1996 book, a medical anthropologist, Sickness and Healing. He's also a doctor. He says, we would not want to describe a person as sick from the instance of a first cell division for cancer, since this disease might never follow or might only follow decades later. With a definition including all first events and causal processes as sicknesses themselves, we would all be sick from birth. So he's making an argument here that this is a reductio ad absurdum argument. He's saying it would be silly to try to find the first instance of cell division because then we'd all be sick, and that would be silly. So this is his argument, because it would be silly. Similarly, George Canguilhem, a brilliant historian of medicine in a book called The Normal and the Pathological, defined health very nicely as health is being able to fall sick and recover. In other words, to have health doesn't mean you never get sick, but it means that when you get sick, you recover. And he says, health is a set of securities and assurances, securities in the present and assurances for the future. So I can't just be healthy right now if the next moment I get sick. The very definition of me as healthy is that I'm not going to get sick right away. And then he makes one joke in the book, but who isn't in the shadow of a traumatism, borrowing a return to intrauterine existence, if even then? And again, he's making this as an absurdity, that we can't let health go all the way to any risk because that would be absurd. But then you look around today. This was a few years ago in Time magazine. Here's hypertension. Children are considered hypertensive if their pressure is consistently at or above the 95th percentile for their height, age, and sex. And then you have a chart that goes all the way up to age 1, meaning that by definition, 5% of all 1-year-olds are hypertensive. Right? Again, it's a funny thing. I hear a little bit of laughter. It's kind of like, wait, what do we do with this? And you see, in this article, Dr. Ronald Goldberg quoted as saying, so there's a lot to be said strategically for identifying people at risk at the earliest possible point. So here's like a grammar difference. These people thought it was a joke to say that. They thought they were making an argument by saying no one would really want to go to the earliest possible point. But today, it's actually something that we regularly talk about. We even talk about having pre-health advisors like that you get when you're born that kind of talk about your full risk. And Mickey Smith, the author of one of the standard textbooks, still, it's gone through many editions of pharmaceutical marketing. So this is the book that trains pharmaceutical marketers. He says, for as long as everyone is destined to die for some cause, a decline in one can only come at the expense of an increase in another. This is an inescapable truth, yet there seems to be some failure to recognize it. What society, the pharmaceutical industry, and to some degree is doing is making conscious or unconscious decisions about tolerable causes of death. So here's culture, right? Our society is deciding what to worry about. He's also pointing out that we all have 100% risk of dying, and if we reduce that risk of like heart disease by 5%, you still have 100% risk of dying. So part of the point he's making here for marketers is that this is a brilliant market, because no matter what you reduce, you still have more to go. So when I was talking to these marketers, we started getting into some interesting territory, namely a shift within pharma companies in which marketers came to play more and more a role in designing clinical trials. And so clinical trials then became a really interesting pressure point. Clinical trials are kind of brilliant instruments designed starting in the 50s. The Framingham Heart Study was a big study that helped really us learn about statistical causes of illness and of like smoking and its connection to cancer. Continuum notion of health. This is a notion of the fact that health is a continuum. So your risk of a heart attack is not non-zero, like we all have some risk. And then where does it become enough of a risk that you should treat it? This is the issue with a continuum notion of health. Where do you draw the line? Where does it end? Where does it begin? And it creates a new definition of health, namely that if I'm reducing my risk of something, I'm healthier. Right? And it's an interesting thing. It's an interesting thing, one, conceptually, just thinking about it. It's a brilliant discovery. That's something that mass medicine helped create, and it's useful. At the same time, it can have pressure put on it. So here's one complaint. This was in The Nation, a leftist magazine, right? Almost 3 times as many people, most of them in tropical countries of the third world, die of preventable, curable diseases as die as AIDS, malaria, tuberculosis. In 1998, these claim 6.1 million lives. I'm skipping a little bit. He says they died because it doesn't pay to keep them alive. Only 1% of all new medicines brought to market by multinational pharmaceutical companies between 1975 and 97 were designed specifically to treat tropical diseases plaguing the third world. 13 out of 1,223 medicines. So when I give articles like this, there's more recent ones, to my students, they're kind of outraged. And their tendency is to think that the pharmaceutical industry is behind this. Like, why can't they put their energy into tropical diseases? But as I started reading pharmaceutical textbooks, you find things like this one by Thomas Bartfy, who used to work for a pharmaceutical consultant and a pharmaceutical publisher. They say one of the significant problems for the pharma industry is that of the 400 disease entities identified, only 40 are commercially attractive by today's requirements of return on investment. Society needs to find a way to make more diseases commercially attractive if it wants pharma investment in treating any of the other 350 diseases affecting hundreds of millions of people. Or, in Greener's A Healthy Business, a guide to the global pharmaceutical industry, pharmaceutical companies tend not to invest in tropical medicines because they are unlikely to recoup their investment. Given the pressure on pharmaceutical companies to maximize the return on investment, this attitude is unlikely to change without a major change in shareholders' attitude. So in most books, I found some part of this, right? That people going into the pharma industry, this is not our problem with them, or I don't know if I can even say "our" in a room, right? We're all part of this industry in various ways, and many of you are training to enter it in some form. This is a problem within the industry. And they're blaming society and shareholders. They're blaming all of us, our parents, etc. right? I have mutual funds. Mutual funds tend to invest in good, safe investments, and pharmaceutical companies are super safe. So I'm making money by putting pressure on pharmaceutical companies to make short-term returns. I'm helping force companies to grow, because that's what grows share value. So shareholders in society, the pharmaceutical industry is saying here in these quotes, we would love to invest in tropical diseases, but we can't make money doing that. Or really what they're saying is we can make so much more money investing in other diseases that we can't choose not to. We can't choose to invest in these more smaller diseases or diseases that won't return as much investment. I had one point where I was playing with Marx and capital and just switching around some views and between 19th century capitalists. Marx's method is actually weirdly similar to mine. He mostly read what capitalists of his day were saying. He didn't say that they were doing bad things necessarily. He said, this is what they're saying about themselves. And this is what I'm curious about quotes like what I have above, and this is this translation. Here's the twist so peculiar in capitalism and biomedicine. The company that one loves because it makes healing medicines becomes secondary logically to the money it returns. The disease it wants to cure becomes secondary to its market size. It comes to appear that it has to be this way. And over again in the history of pharmaceutical companies, you find this problem, that they talk about losing their soul. They talk about the fact that ever since the 1980s, as they became giant companies and blockbuster drugs became crucial to their bottom line, and I can talk more about this if you're interested, that their pressure is to maximize the number of new prescriptions, that the way they have to interpret return on investment is maximizing new prescriptions. So here's one example from Quintiles, which many of you probably know is one of the largest contract research organizations. It basically does everything a pharmaceutical company does, except it does it as an outsourced mechanism. So it helps pharmaceutical companies deal with variability. So here's what they call, and again, it's interesting, I love paying attention to quotes, right? This is the classical design. This is how things used to be, where there's an isolated dialogue between research, early development, large-scale full development, and approval of a new drug. And they have this quote, "We must not pollute the fertile field of R&D with accountants and marketeers." So this is what they call the classical model, and then this is what they call the current model. Here's where you have commercial inputs from the very beginning. You now have marketing making decisions like what diseases to study, how to study it. I mean, marketing gets involved in the biostatistics. And this over and over again, in my book I have lots of quotes on this, where you have people in the pharma companies complaining that, well, we can't let clinicians decide what diseases to study or even how to study them, because they might do something stupid like study a disease where it will cost more to research it than we'll get back in profits. And they're like, as a company, we can't let them do that. We need to tell them what things to research. So this is a change that we're all inside of. Here's another quote just from pharmacoeconomics plays a pivotal role. Drug development is very capital intensive, and even big indications such as malaria and tuberculosis are affected. This means that small indications suffer regardless of how good the science is. If drug discovery were a science-driven activity, one would expect scientists to be running drug companies. However, since Roy Vagelos of Merck retired in 1995, no big pharma has been run by a scientist. They are all run by people who are trained in economics. So and this is true across the board for big companies. All big companies have shifted from having the people who are in the industry, the managed, running factories, becoming CEOs. Now the track is CFOs and sometimes CIOs. So chief financial officers becoming CEOs or chief information officers. And this just has to do with the way big companies capitalize themselves and the kind of pressure that they then get put under to maintain regular returns, that you need a financial officer making the decisions for the company. And you see this recognized, you see the guidelines, the kinds of things that clinical trials produce. Here's a Forbes magazine just saying cholesterol guidelines a gift for Merck, Pfizer. And this is in the business press. And often the first place you read about clinical trials is in the business press because it matters so much for shareholder value. And again, just one more quote. The company's order of priorities is extremely clear. The major factors in selecting a clinical candidate in the company's own priority order are 1, marketing, 2, internal economics, 3, scientific, technical, and legal issues, The regulatory and marketing groups and then the clinicians can always override scientific consideration. They call the shots. Under current circumstances, this is unavoidable. Decisions of this caliber are so expensive and so delicate for the company's future, they cannot be left to scientists and clinicians alone. So I just want to show you, right? I don't want anyone hearing me as saying these companies are bad. It's actually quite stunning to realize they are aware of all of these problems. They struggle with it, and they're also trapped by it. In other words, we as a society have trapped our research in companies who themselves are trapped by the priorities that we put on them. So if companies are in charge of medical research, here's just the kind of nutshell conclusion of this. Clinical trial research becomes an investment. So if a company is going to spend $50 to $100 million running a clinical trial, they're seeing that as an investment. They're judging it based on what comes back. The goal is therefore to grow the amount of treatment because the value of that clinical trial is going to be how many pills it sells. Health, then, in this equation for a clinical trial equals medication. So when I say pharmaceutical companies define our health as a subtitle of my book, I mean that health for them means the amount of treatments that they sell. So again, we may think that treatment, the goal of health should be the reduction of treatment. For a pharma company, the goal of health is increasing treatment. So rather than health is not needing treatment, health becomes risk reduction. Now, I'm not talking about all medicine. There are there's lots of research going on and so on, but I'm talking about the major thing driving pharmaceutical research in companies today and the major growth. When we show health growing, it's growing through these mass treatments. And it grows by treating risk reduction, and I want to show why. Health and treatments, the pressure is therefore that they need to continually grow. So one way to think of this is the only question a drug company can afford to ask is one that adds treatments to our life. There may be many things where they could ask a question like, how could we, like the number needed to treat for a statin, let's say it's 200. It's usually higher for most. That means you have to treat 200 people every day for 5 years to have one reduction in an event like a heart attack. So they are never going to ask a question like, could we spend a lot of money and figure out how to get half those people off of statins? Because all that would do is destroy their bottom line. So they can't afford to ask a question like that. This was first, I think you could talk about this as what Geoffrey Rose was knighted in England for helping discover mass prevention. And a doctor talking about mass intervention for relatively low incidence diseases. This was the kind of beginning of thinking of like, can we treat heart disease? And he's asking this as a public health professional, or at least what comes to be incorporated in public health. Like, what would it mean to start thinking of treating a bunch of people to help some? Because we can't quite identify which ones are going to get it. So this is the kind of idea that we all have risk. And he has this chart in his book. And I can't go into real detail, but just to notice that, here we have age across. So each column is a different age group. And then if you read, let's just look at the middle line here. So what this means is that if you look at men 55 to 64, you would need to screen 230 of them to decide who needed to be put on treatment. And of those, 100 would be treated for 5 years to prevent one death. He's using this as an example. On the other hand, you'd have to screen 137,300 women, age 25 to 34, and put 20,000 of them on pills every day for 5 years to prevent one death. And when he puts these two next to each other, he says, for the men, this would be really good. We would all consider this to be a good drug. This, we'd probably say, is far outweighed by the side effects and just the costs of all that screening and all that treatment. So in his book, he's like, this is the prevention paradox. Where do we draw the line? And it's a great book, but it's really interesting because he doesn't consider in any way that the decision about running this would ever be in the hands of a company. Now, if you were going to run a clinical trial, though, as a company, which would you run? Would you run a trial that just had men over 55? You'd get a drug that's really targeted, would probably help those people it was given to. Or what if you were going to run a trial that had everyone over 25? Many of you have heard the kind of quote, like everyone over 30 should be taking a statin. So if we just did, but if we only could run one trial, at the end of it, we'd only have one fact. So if we ran the trial with everyone and we get to include the high-risk men in, but we basically run a clinical trial that's more or less designed so what it does is if we have enough people in that trial, we could actually say everyone over 25 could benefit. And we don't do the breakout. So this is the kind of challenge for a company. Unless one takes the wholly and unrealistic view that the saving of a life is worth any price at all, then it's hard to justify. This is what Rose was struggling with. And what he said, therefore, is that when you run a trial like this, what it really means is you're diagnosing not a disease entity, but a case for treatment. That what you do when you run a clinical trial today for a mass illness like this, when you run a clinical trial on risk, you're not trying to find something. What you're actually trying to identify is a treatment effect. In other words, the conclusion of the trial is treatment. And Bernice Schachter, another pharmaceutical consultant, writes, if the team elects to seek approval for a narrow subset of patients with a certain condition, then the market for the drug may be too small to make financial sense for the company. Again, I'm just trying to show you that this is their critique of themselves. This is the critique of the problem that they're stuck in. Should they develop for this specific use and that one, but not the one unlikely to succeed or generate a sufficiently large market? So she's trying to actually pose the question to people entering the industry of the problem that they face, which is they have to ask financial questions even if they want to ask health questions. And you get this joke, right? The old pharma saying, well, it's good to have a pill that cures the disease. It's better to have a pill you take every day. And so one of the things that's happened over the last 20 years is a lot of discussion of move toward chronic treatments. Here's this really interesting study in the British Medical Journal in 2006 by Douglas Manuel and others. Here what they were trying to do was to compare cholesterol guidelines, heart disease treatment guidelines from different countries and different times. And so each of the markers there, and then this curve they posited as the optimal curve. So here's a curve that's a kind of really interesting population problem. It says, I don't know if I can, can you see that? Okay, so at 5%, so these are percent of the population. So if we treat 5% of the population with statins, we would save, they're talking here, maybe 10,500 lives. And then as you move over here, you see with this kind of logarithmic curve, 10% of the population, you'd get 14.2, and over here we could treat 25% of the population and get maybe almost 17. So we're talking about where, so here's the question, right? Where as a culture, where as a society, where as a company would we want to draw that line? And it's an interesting article because again, it doesn't actually consider corporate or financial pressure on the design of these guidelines and trials. What they're trying to do is show here different countries and guidelines, but you see that the latest US one at the time, the 2004 one, is far over to the right, right? And that if you're a company, the further right, the better, right? That's amazing market size, right? They're talking 25% of the population being indicated for statins under this type of guideline. So here again is this kind of, these are just kind of trying to give you different ways of thinking about this. And then the second one is, and this was just happening at the time that the Prozac website was going up, you see all these kind of dotted lines. So the idea here is you fall down into syndrome, and that's kind of depression at the very bottom of the curve, right here, and then you take the drug to respond and you start rising above the level, but then there's all these risks. And the final risk, recurrence, is that the same treatment, the antidepressant that gets you out of depression, then is said on the basis of other clinical trials to prevent future occurrences of depression. So the treatment first works to get you back to health, but then, or normalcy in quotes, and then it now is used to maintain that. So again, it's this kind of conversion toward chronic treatments. And so this is from Reconsidering Direct-to-Consumer with Patient Behavior in Mind. Healthcare has dramatically changed in the past 35 years. Treatment increasingly migrates from a doctor who directs hospital care to patients who now prevent illness through medication in an unsupervised community setting. Patients are often unable to determine if they need treatment at all or only when a product is working. This difficulty is only likely to grow. As researchers unravel the molecular basis of an illness, manufacturers increasingly turn incurable diseases into merely chronic ones. So the pressure on companies is to push chronic treatments because they're hundreds of times more valuable. If you're taking a pill for the rest of your life, that's a lot of pills. So in terms of the kind of size of that market, it's much larger. And on the original Prozac website, again, I'm just echoing this, that teaching us to think this way, that feeling better is not enough, right? That just because the antidepressant has gotten you out of depression and you feel better, now you have the risk of recurrence to deal with, so you should continue taking the drug. And then there's this kind of thing from the Journal of Pharmacoeconomics, why drugs are more profitable than vaccines. In a simple representative consumer model, vaccines and drug treatments yield the same revenue for a pharmaceutical manufacturer, implying that the firm would have the same incentive to develop either one. But they talk about they've done the full model. Like, what happens if your vaccine works? One reason for the breakdown of the revenue equivalence is that vaccines are more likely to interfere with the spread of the disease than a drug treatment, thus reducing demand for the product. And it's it's a kind of eerie way of talking, right? Demand for the product is reduced because vaccines help people. By embedding an economic model within a standard dynamic epidemiological model, we show that the steady state flow of revenues is greater for drug treatments than vaccines. This is kind of one of those totally frightening articles that it's good people doing pharmacoeconomic analysis, just thinking of the value of treatments for a company. And so what they're saying is that if you invested in a vaccine and it actually worked, you destroy your market, therefore you wouldn't make as much money as if you invested in a drug that just treated people without interfering with the spread of the disease. That would ensure a market that would go on. So it's a kind of, again, as I read this literature, I'm like, wow, they're actually saying all this stuff, and this is how companies have to think. And here's another quote that again made me freak out for a while. Looking at the business of mental disease objectively, but without cynicism. It's a weird turn of phrase there. A common denominators of these indications, these are mental illnesses, is that they share the distinction of not being cured by these treatments. This makes the market even more attractive. The patients have to take the drugs chronically. Not only are the diseases not cured, but there are few treatments that give 100% relief to those who have a syndrome. All the usual response rates are 60 to 70% for a really good drug, and it's actually much lower for most drugs. So what they're saying is that mental illness is a wonderful field to develop treatments for because you can get clinical trial signals, but you're not going to cure it, so those people are going to continue to need it, and your treatments aren't going to be good enough, so you get to add more and more treatments. And if you've noticed, the trend over the last 5-10 years has been a lot of advertisements that are like, if your antidepressant isn't working, don't switch, add ours. And so this is a model that, again, for business reasons, is the one where the most pressure's on, meaning this is where the research dollars are going because it returns on investment better. And from another article, a marketer's real enemy is less the share loss to competitors than the cumulative effect of patient attrition over time. So again, here, viewing it as a marketer, viewing it as a company, the thing you're most concerned with is where do you lose value? And the place where you lose value is when someone who should be taking a drug chronically stops. And you can see Forbes, at one point, they once had this article on pharma's new enemy, clean living. It was an article about all these alternate treatments than taking drugs. It's the only issue of Forbes that doesn't have pharma advertising in it. I think they learned their lesson or something. So here's from Mickey Smith's Pharmaceutical Marketing. Again, I want to listen to the grammar here to see what they're saying and not saying at the same time. So here's patients with chronic condition X. You imagine 1 million patients who have a condition. Then of those, who visits the physician? 900,000. And then how many prescriptions actually get written and how many are authorized? How many new prescriptions are filled? Like how many times do they go back? So what he has over here in this column is prescriptions lost. And he puts it in quotes because he knows it's kind of weird and creepy and probably wrong to say lost. But from their idealized perspective, everyone with the condition would take the drug and continue to take the drug. So then from that point of view, anyone who doesn't go into the doctor, anyone who goes to the doctor and the doctor decides they don't need a prescription, anyone who doesn't fill it, or anyone who doesn't come back because of side effects or anything else, all of those are loss from their ideal market model. And down below, he drops the quotes, but he kind of talks about the original potential and then the total prescription loss. So here, it's just, all I'm trying to point out with this, I mean, this is, if you go into marketing, this is how you need to analyze the potential market for something. But what I'm just pointing out is that there's this kind of like, he knows it's kind of weird to think that everyone who doesn't take the drug that the market size said they should is loss. But from thinking from a company perspective, that's the kind of analysis. The economic driver in care has shifted from physician to patient. While physicians continue to control episodes of short-term acute illness, such as hospitalizations, patients increasingly drive the financial and clinical outcomes for chronic diseases through the simple daily act of taking a pill, often over a long period of time. So then here's the crux of why they're writing this, moving beyond market share. In financial terms, the shift from acute to chronic care means that between 75 to 80% of a prescription's value is now concentrated in the patient's return to the pharmacy for refills. And I've sat with marketers and they've showed me this amazing kind of flow chart. And it's like, here's all the people that could possibly take our drug. And here's that loss equation of how many actually end up getting prescribed. And then there's this little loop, which is now they're on a prescription, do they keep getting it back? And they're like, all of our value is here. And this is the big press right now in terms of compliance, because you want to drive that. So Express Scripts, which is one of the pharmacy benefits companies in the country, I think they do about a third of all the prescription benefits. They have this amazing report that all of you going into the industry should completely look at. It's a really interesting report every year called the Drug Trend Report. And what the Drug Trend Report means is for each illness, you look at, or for each illness class, you can look at things like they're tracking the prevalence here, like 10.4% of all the insured patients in their group have it and are being treated for it. The average cost of a prescription, the number of prescriptions per user per year. So you can see how many times, like the average amount of medication on those and this particular, and so then you can see on over here on the left, the influence on the trend. Now, first thing to notice is that for them, the size of a depression market is the amount of dollars in it. So the prescription, one of the major forces on the trend is patent expiration. So that from their point of view, or from the point of view of the companies that they're making this kind of trend report for, when things go generic, the trend goes down. So if more people are being diagnosed, but it's also going generic, then the trend for the market size for depression might stay the same. Or in this case, going down because of the mix of generic and branded drugs. What this particular report, the 2011 report, was concerned with was pharmacy-related waste. So as a pharmacy school, it's worth looking at and thinking about what they're tracking and what they consider waste to be. Here they're pointing about 42% of patients are non-adherent for medication therapy. And they now spend a lot of time to activate good intentions. Express Scripts is leading the way in the convergence of behavioral sciences and healthcare, an approach we call consumerology. Trademark. Don't repeat. This unique approach provides plan sponsors with practical solutions that deliver better health and lower costs while preserving individual choice. And then they analyze different types of waste. And again, waste from their perspective is anyone who doesn't refill. 45% of adults in the US have one or more of the conditions treated by medications in the top 3 therapy classes. So here you can see this. And then if they're saying, like, if we can improve adherence here, we can get $100.8 billion of waste can be eliminated. Now, this is a really tricky number because this is actually like money that's not spent on health, right? If someone decides to stop taking their drug, from the perspective of the industry, that's a loss of that dollar. That's waste because they should have had that dollar spent. People should have taken that pill. So it's really, I'm just trying to get you to see a little bit from the industry's perspective where dollars are what matter, not health, however else we define it. So they say, this is a problem, right? All these people are on a prescription that they should take for the next 5 years, but somewhere along the line they stop, and that's waste. reflecting on the success of screening for many medical conditions, we started to reframe non-adherence as if it were a medical condition. In other words, what if we treated non-adherence as a disease? What might we do differently? This is one of those where I'm like, I thought I was writing science fiction when I said stuff like this, that this trend was going here, and then it turns out they're way ahead of me. So they talk about it. One solution was immediately clear. We should screen for non-adherence. And they develop a program called ScreenRx, in which when you go to a doctor and get a prescription, the doctor then gives you a screening tool to figure out what are your various risks of non-adherence. Is there a chance you just will forget to fill your prescription? Will you forget to refill it? Maybe they should mail it to your house. Will you not be able to afford it? Maybe they can get you on a program so you continue to afford it. Maybe you'll have a side effect. Can they maybe add something right now to prevent that side effect from stopping you from taking it? So they're putting this, part of the thing that kind of I was intrigued with is they read all this amazing behavioral stuff about changing people's behavior, and instead of applying it to health, like how can we change people's behavior so they wouldn't need medication in the first place, they're putting all this amazing research into changing people's behavior so they take the pills. So I'm just struck by a little bit of that kind of dissociation. It's called ScreenRx. So it's the first capability by identifying members who are at risk for non-adherence. So here's the additional risk. I don't even think you can call this medicalization, right, because it's already medicine. It's some new thing. So now you could be at risk for not continuing to take your pill. So this is the kind of first ending, right? If pharma companies, I don't know how much time I have. Oh, I guess I should wrap up. Sorry, I don't have the timer on here. Okay, so we've gone through this. So what we don't learn. One of the things we don't learn under this new way of doing medical research, if what we're asking is what the return on investment is for the clinical trial, we don't tend to learn long-term effects of drugs, because studying long-term effects would just shrink a market. How long do chronic treatments stay effective? When can we stop treatment? The number one thing when I've given talks to doctors and talked to doctors is they're a little freaked out about the fact that there's all these clinical trials about getting people on chronic treatments, like Alzheimer's prevention. We don't really know what the long-term effects, like being on an Alzheimer's prevention treatment for 15 years is, and we don't have any studies for how to get someone off. Like, when is a good time to get someone off a drug? Does it continue to work? What are the effects of multi-drug interactions? This is probably like the main concern of pharmacy students, is that people, I was just talking to a gentleman who was taking like 13 prescriptions. The average American takes some amazing number of prescriptions a year. Who studies all 13 together? Who knows enough about what that person's taking? Because most people often see multiple doctors, so there's no one person who even knows all the drugs that you're taking. Actual long-term risk reduction versus overall mortality costs. So again, reducing risk is a population-level notion that's applied to a group of people who are chosen for that clinical trial. It's not how much your risk is actually reduced. So you can actually, if you add up all the risks you're reducing, it can go way over 100%, but of course that's impossible. So we don't really know that math. Population-specific issues, all the kinds of variability that exist, and potential diet, environment, hospital treatments, longevity effects. There's a lot that we don't know. So here is where I think, when I saw this, I was like, oh my God, they're just saying it. Like, what I've just told you is not hidden anywhere. They're saying it really out loud. Don't get well soon. Stay healthier longer, right? It's a different notion of health. It means take treatments, because treatments are health in a certain way of thinking. Yeah. Okay, I'll just stop there. Thank you.
Thank you. If you have any questions, please ask for the microphone.
That was very interesting. Thank you. Do you have any thoughts about the impact that sharply targeted grassroots sort of cyber funding is apt to have on research into some of the less popular diseases?
So you mean like patient activism around certain illnesses that have smaller actual funding? I mean, if there's funding, then it could conceivably be researched. So, I mean, the Orphan Drug Act was one of these successes to like say that there's small diseases. I mean, one of the side effects of that has been a kind of, some of those treatments are costing amazing amounts of money. So you get specialty illnesses is actually a new profit center for pharma companies, because if the individual treatments cost a lot, then they can imagine a return on their investment. So I mean, right? I mean, one of the kind of weird lessons of this is that if clinical trial research is subject to return on investment thinking, then it can only result in more treatments. Like the only facts we've had are about adding drugs to our life, not reducing them. And that's because of the way in which the questions are posed. They're posed within a system that imagines that that research has to result in more, and in fact has to pay for all the research that fails, has to result in enough treatment to pay for it. So if we live in a capitalist system where we want that, where treatments have to grow, or where companies have to grow, and the companies are doing the research. So I'm kind of thinking companies shouldn't do health research. I don't know who would our government be willing to? But it's a weird thing to think that if a company is going to do research, as they tell us, they're only going to ask questions that grow markets. They're only going to ask questions that actually grow treatments in our life. Yes? I'll let the microphone people tell me who to call on.
Listening to you talk, it sounds to me as if the drug companies don't have people's health really in mind. And I've kind of had that feeling for a while myself, that they're more interested in growing the business, and that most Americans are probably on drugs they don't really need. That's how I'm interpreting what I just heard you say.
Yeah, but let me just qualify that a little bit, which is most people at pharma companies got there because they're really interested in doing health research. They're really interested in reducing the burden of diseases on people. So when I say the company, I really mean the company as an aggregate, which is why you have people from within the industry saying, help us, we're trapped, right? Help us, we aren't allowed to ask the questions we want to ask because it won't make financial sense for the company, and that's who we work for. So the only kinds of questions we can ask are those that will make money. So it's a tricky issue. Yeah, it's a catch-22. I mean, if we as a country or as a world outsource medical research to companies under the idea that the market helps drive things, it's become a little weird because the market itself is saying we're only going to fund certain types of research over others. And that's I mean, it is a catch-22 that way. Or we could say the goal of medical research should be to actually reduce medicine in the world. But that would be a different type of question. And it would mean we'd spend money to get rid of things instead of to add things. And right now, I mean, Obama in one of his first addresses to the union said, you know, health is our fastest growing industry, right? So, you know, if I'm right, like if you follow my direction, we're going to kill economic growth in this country. Like if we get rid of the engine, like growing, like why is health growing? I still find that a really interesting question. Like, we're really smart people. Can't we shrink health? But then it would hurt the health of the nation.
How does this compare in different Western countries with different healthcare systems, like Canada or Sweden or Europe or New Zealand and things like that?
Yeah, it depends on who you ask. When I first attended direct-to-consumer marketing conferences, the marketers there were talking about the EU at the time as being like the best thing for them because then they could just put all their pressure onto one regulatory body instead of all the separate ones in Europe. Like even though you can't advertise drugs in any other countries except the US directly, the way these commercials do, you can advertise illnesses. You can have disease awareness campaigns for illnesses that sometimes even have only one treatment. So there's still an increase in medication in those countries. So these, you know, because this is happening at the kind of clinical trial design stage, these are facts. You know, I'm not saying that these are, like I'm not talking in any way about cheating. Like some of that does happen in the industry, but all I'm talking about is they're playing, if they play all by the rules, we still have this problem, which is that they're only asking certain questions and not others. And that affects every country. So the guidelines all over the world keep going up, or they keep going down, meaning more and more people are put on chronic treatments. And so that is something that kind of bypasses what you might think of as the right stops on this. Again, because these are facts. They're just, in a sense, facts about the wrong questions. Or we could ask better questions. Let me just put it that way.
As I've looked at some of your slides, I guess I'm going to take exception to what you've said. First of all, many of your slides are from the early 2000s. You made a statement that drug companies aren't led by folks with science degrees. Well, if you look at Pfizer, that's an individual that has a PhD in microbiology and an MD. You look at Lilly, that individual has a PhD in chemistry, in organic chemistry. So there are people that have science degrees that are driving these companies here.
Yeah.
My challenge to you is that you're showing me data from 2002, 2003. You're showing me older data.
Yeah.
The current change of healthcare systems is having pharmacists and physicians and all the folks involved with patients to help manage their medications. There will always be chronic diseases. We cannot stop that unless we know how to stop the chronic disease.
Yeah.
And I think that there are lots of really thoughtful people in the industry and in the health sciences and in health education that want, and in the health professions, to help patients manage.
Yeah.
I think that we need to be a little cautious on how we say that there's the big bad drug companies, because they are spending a lot of money to try to get it. We haven't even begun to think about personalized disease and trying to get the right medicines to the right patients based on the right disease. So I would say that I would ask you to go back and look at your data and see what's happened, in the later. You show us 2011. When you talk about adherence, we're talking about adherence because we know if patients aren't managed, they are going to be at risk for serious complications, heart attacks, strokes, other things. And pharmacists and physicians and nurses and PAs, what we teach our students to work in this healthcare team are helping patients to manage their medications. And sometimes the best management of medications is no medications. So making these blank statements puts me a little upset with all the students in this room that are trying to do a good job to take care of patients. So I would ask, if you're going to continue to look at more recent data, look at the change with accountability care organizations, which are going to be having to get a certain cost to manage their patients. They're going to want to get patients off. So, I understand your concerns. I can see that, but I would like to think that we need to look at where we're at in the current healthcare system versus what I see. Many of your slides were from 2002, 2003, 2004, and that game has changed dramatically since then.
Yeah, great, thank you. On the one hand, first of all, I use these slides because these are the ones that are in my book because my book took 10 years to write. I'm a slow thinker. So I'm tracing, first of all, the change in the way we talk. And the second thing is, yes, I totally agree. I mean, there's lots of good things we can do with health and finding ways, when you say the best treatment is no medication, I totally agree, and there are lots of people working for that. What I'm trying to show here is, at this level of industry discussion of how to run clinical trials, they're talking about the struggle, the pressure that they're under to make clinical trials have this return on investment model. So they're talking about that pressure on questions. And it's not me, right? I'm interested in thinking about how what they're saying impacts the type of health that we do have. And so I totally agree, and I'll repeat something I said earlier to some of the students. I mean, I was once giving a talk on this kind of thing about how insurance companies underwrite research into how the pharmaceuticals that people are getting on the basis of clinical trials could maybe fight back. The insurance companies could fight back against some of this trend in pharmaceutical development. And I was a vice president of Kaiser who came up to me afterwards and said, oh, good try, little guy. He said, in the short term, we want to reduce costs, but in the long term, we want to grow the pie too. That as for-profit companies, they need to grow as much as the pharma companies need to grow. So what he was discussing was that in the short run, industry wants to reduce costs, but they also have a duty to their shareholders to make sure that next year they make more money. And that type of duty puts even insurance companies and HMOs under pressure to grow. And I will continue to look at this, but I am concerned that if it's a for-profit healthcare company that's overseeing a kind of pocket of money, this year they really want to, once they have the money, they really want to reduce all the costs associated with that, and they may choose no treatment. But next year, they would love a reason to charge everyone slightly more money. So that's what I'm totally up for this game changing. I do not like it the trend. I would love to see total healthcare costs cap and not keep going up. I would love to see the amount of money spent on drugs go down. I would love to see the number of prescriptions for lots of drugs that have a high number needed to treat going down. I will help anyone who wants to do that. Now look at some of these organizations that you're talking about. But I do think that if behind it is a company whose job is to grow, they're going to be under pressure to find a way to make sure that they keep growing. So it'd be much better if nonprofits or some other mechanism was in place than companies whose job it is to grow. That's the dilemma that I'm trying to track, and I totally agree that there's lots of other pressures going on that are really good. And I'm sorry if I gave the impression that it's all bleak. I don't mean that. What I'm actually trying to show is that we actually have allies everywhere in this industry who are worried about the same trends that we're talking about, that I'm talking about here. That this isn't the industry wanting to do this, it's the industry saying we have to do this. And so I think there are places to make alliances that will change this. Yeah.
Joe, aren't you in a sense talking about, basically living in the United States? People are bombarded on a daily basis to consume other things, foods, buy cars, do a lot of things that are not necessarily good for them. So to make up for that, for those, to also consume a lot of drugs to somehow to balance out the excessive consumption of other things. So we live in a culture where on a daily basis, every person in this country is bombarded by all kinds of marketing. And how does one resist that? I mean, how does one go about their daily lives resisting this barrage of marketing, whether it's buying food, buying education, buying cars, buying this and that? I mean, is there any way out of this system? That you are, I don't, go ahead.
How to solve American culture? I don't know. My job is to track cultural change, not solve it. I mean, the one thing I've talked about with some people about, if we open source health data in this country, like if all of our health records, which are already electronic, were shareable, we could then analyze that giant pot of data and actually learn a lot about which drugs to get rid of. Right? I mean, we could learn how many drugs people are on that when they're on them for 5 more years don't help. Like all that data exists. So there's a lot of talk of that, and I'd like to see more. And again, all I'm trying to do is think about how does it keep growing? And ask what I've tried to do here is show the forces for that. The overall consumption ethic, there's particular ways. One of the projects that I'm starting to work with some people on is, just to do ethnographies of all the drugs that people do take. How do people take the drugs that they take? But that's something I haven't gone into personally.
Hi, this is somewhat anecdotal, but it kind of ties into what you're talking about tonight. I went to Rite Aid to pick something up, and the pharmacist or the assistant said to me, have you had your flu shot this year? And I thought it sort of felt like an invasion of my boundaries. It's like, doesn't my doctor ask me that? And I looked over and somebody was getting a flu shot over in the corner, and I just felt creepy to me. And I guess now everyone's supposed to have a flu shot. Like if you're 6 months and older, I guess and I didn't know when that changed. Do you have any information about the whole flu vaccine movement? It just seems strange to me. And there was no, I wasn't given studies like this is, why we're advocating for every single person to have a flu shot because this is the impact. And I was really creeped out by it, so.
I don't know the details. I mean, I do know it's been declared a kind of public health necessity in a lot of ways, so I needed to get one because I'm a hospice worker. And it's now become a requirement for hospice workers to get that. And so there are a lot of people who are in health situations who now are under guidelines where it's mandated. And there probably is a history for how that became mandated that probably, I'm not sure. I mean, we're in a kind of funny space with flu vaccines. A lot of the vaccines, one of the ways to make them profitable is to make sure that they're mandated in various ways. And so that's increasing pressure on that. And again, not because there's not facts there. So I don't know the specific history. But flu's in a weird place where some people are being mandated to do it, but others aren't. And then, I don't know, I guess Rite Aid's now in the middle of that where maybe they're required to ask, but not to tell you? They're not mandated to ask? So are they asking because it's part of that training, or it's part of Rite Aid's policy to ask that? Is it at that level? I don't know. I mean,
So several years ago, we realized that many adults were not getting vaccinated for common diseases like influenza. So across the country, every state now allows pharmacists to serve as immunizers because there are patients that couldn't get to their physicians. So this is part of the role that pharmacists are doing to promote, promote wellness, to prevent vaccination. Pharmacists are asked because they're doing that as a thing to help their patients, so they can do that. They're not mandated. It's a service that they provide. And, we know that if we didn't have pharmacists doing, there'd be a lot more people that wouldn't get vaccinated across the country here. So that, we have to be careful and say they're mandated. They're not
No, I was
mandated.
asking if they were mandated.
No,
I
they're
don't know.
not
I was
mandated.
mandated
And
as a
the pharmacist
healthcare
was doing
worker.
that to provide that service so that you could have that potentially, and that's part of what we're trying. We're all a healthcare team trying to maintain, and we know that these are preventable, that with the vaccination we can prevent a lot of cost. And that's what people forget about. If we're not treating that, we're paying for them in acute care cost in our hospitals and everything else. And we know that one of the risks that older adults get if you're not vaccinated is the potential for some of these serious diseases that can be prevented through vaccines.
First, I'd like to thank you for your presentation and the information that you shared with us. And when it comes to measuring if we're doing better and if we're going down the right road, I think we can just look at a couple of simple things. It's 2013. We've spent billions and billions and billions of dollars, and we haven't cured cancer yet. It's 2013, and 25,000 children a day die in third world countries because they can't fight simple illnesses. The same thing comes with clinical trials. One of the first things that looked at when they talk about clinical trials for cancer is how many people get this cancer every year. And if the number is low, it doesn't get the money for the trial. But 25,000 women will die of ovarian cancer. So even if your data's a little old, we still haven't come far enough, fast enough to make this a better picture.
One more question, and are we?
Yeah.
Thank you for your talk here tonight. I'm just curious about what you have found in your discussions with physicians and what their reaction is. Do they feel caught in this situation where they're providing these drugs, they're making more money because you're coming back to see them again in 2 weeks? Or do they feel an ethical or moral responsibility to get some people off of these medications? What do you hear from them?
Yeah, lots of things, all of the above. Most physicians are caught in systems where they can't spend as much time with patients as they'd really like to, where, most specialists feel that patients who come to them are on the wrong drugs or on other drugs, and they tend to talk about primary care physicians. Primary care physicians talk about, patients who come to them through another system. There's a lot of, I don't know really how to address that. I mean, it's a question of like where they get their recent facts from once they've been trained. You know, there's books written about the pharmaceutical reps and how they represent drugs. There's concerns about off-label prescribing, where a rep tells them about another use for a drug than the drug it's been approved for, than the disease it's been approved for. And then they're kind of stuck because they don't know how to research it further. I mean, there are a lot of issues. I mean, all the doctors I know are trying as hard as they can to give people the best treatment they can. And they're in a world where they don't always have as much information as they'd like. And some of the pressure I showed you, some of the kind of surveys of primary care physicians, the amount of time they can actually spend with patients per visit is just stunningly low. So that's an increasing reliance then on mass techniques and not the ability to do the kind of personalized care that they'd really like to do. And so our country, but many countries, getting that level of personal attention in medicine is one that often requires a lot of your own money, as opposed to, an insurance system or something like that isn't doing the job that we'd like it to do. So, I think, and most physicians, again, I said, there are lots of questions they have that they can't get answers to. So how do they, in the time that they're given with a patient, figure out what prescriptions the patient is on? How do they figure out which prescription is working? So most of the tertiary care folks, like the psychiatrists or cardiologists, they're like, I need to see a patient every week to see if the drug is doing what I think it's doing. Or if they're having a side effect, it needs monitoring. But the costs of that monitoring are often prohibitive for them and also for the patient to keep coming back. So there's a lot of things that we could be doing, but that are, we need help doing. And I know there's lots of people trying to do that better. And there's various attempts to do a lot more home monitoring, to measure people at home and send those results in, and to do a lot more careful tracking of side effects and so on. And that could go a long way toward helping some of these problems. So, this isn't something that I've spent a lot of time doing. It's more when I talk to them about what I'm doing, hearing their stories about what it's like to be on the other side of this equation. Having patients coming in demanding a drug that they saw advertised, and knowing that that patient might go to another doctor and get it, and they might feel like, well, at least I'll trace this person. I'll try to see if this drug is doing something good or bad to that person. And so, in a sense, prescribing even when they're not sure it's the right thing. So these are the kind of ethical dilemmas that physicians face, are often of this kind of nature. I mean, and this is, yeah.
One more question, though. I mean, this is the last question. What is a pharmacy student to do? What is a pharmacist to do? I mean, what I'm saying, it's a question. It's like if you have a headache, what do you do? And the same would apply for physicians and applies for a lot of other industries. I mean, we know a lot. We can approach these issues critically, but do we need this? Do we still need these professions to do their thing?
Yes.
Yeah,
definitely.
Thank you. That's what I wanted to hear.